Okay, tell me when to start.
Okay, just start.
Oh, hello everyone. I'm Dr. Dean from the Medical Physiology Department, University of Nairobi. And today I'm going to present to you a short look at the assessment of hearing. And this will be in 4 different sections, which will be self-explanatory. So we'll start by just introducing the basic physiology of hearing. And then we will look into the details of how the basic assessment of hearing is done to enable us to find out the level, presence of hearing loss, level of hearing loss, and if possible, the cause of hearing loss. We start briefly by having a look at the anatomy. This is just a reminder. You have external ear, which has the pinna and the external auditory canal, which ends at the tympanic membrane. Then you have the middle ear, which is connected to the nasopharynx by the pharyngotympanic tube. And the tympanic membrane has a connection via the ossicles, the malleus, the incus, and the stapes, to the inner ear. And that inner ear is where the processing of sound is done to convert it and transduce it to action potentials of the cochlear nerve. And then, of course, as you all know, our hearing is done by our brain. Sound is a longitudinal waveform of energy, and it has 3 very important attributes. The first attribute is frequency. Frequency determines the pitch and the tone of sound. And this is measured in hertz. Generally speaking, our range of hearing is approximately 20 to 20,000 hertz. Loudness is determined by the pressure of the waves, and this is generally measured in decibels. Thirdly, the sound has velocity, which is generally more in solids than in air, but since we are normally immersed in air, this is not a very big consideration for us. What is very important to remember is something called the media interface impedance. When sound moves from one medium to another, there is impedance, and the design, the evolution of our ear is to compensate for this media interface impedance, as we shall see in due course. The decibel scale is a logarithmic scale that is used to measure the sound level, loudness of sound. And generally speaking, the reference sound pressure is the least amount of sound that can be heard by a normal hearing person at a specific frequency. And we measure the measured sound in relationship to this reference sound pressure. When you work out that formula, you find that you get a decibel scale in which it's very important for you to remember that 0 decibels does not mean 0 sound. It does not mean the absence of sound. In fact, 0 decibels is the threshold of hearing. And as you can see, 20 decibels is about a whisper. Conversation, and average conversation is about 30 to 40 decibels, and so on. 140 decibels is probably one of the loudest artificially produced sounds by our jet airliners. Briefly, to see what happens before we actually perceive sound, the external ear, 2 important things happen. One is that there's conduction, and conduction is simply the movement of the sound in the from the external auditory canal towards the tympanic membrane, and there is a degree of amplification due to the size, shape, and orientation of the external auditory canal and the pinna's shape, size, and orientation. There is what we call sound wave amplification, and this results in some degree of increase in the loudness of the sound before it reaches the middle ear. Once we reach the middle ear, it has to be conducted from the tympanic membrane right into the oval window of the cochlea or the inner ear. And this is the first phase that the sound waves have to change from traveling in an air medium into a solid medium. So there is some impedance from there. To compensate for this impedance, the middle ear has evolved a mechanism of amplifying sound. The mechanisms of amplifications are several, but generally speaking, the area of the tympanic membrane in proportion to the area of the footplate of the stapes, the lever-like action of the ossicles, and the tympanic membrane buckling effect. These three effects increase the sound as much as 50 to 80 times in terms of loudness. This compensates for the impedance between the two phases. Once you reach the inner ear is a coiled bony tube which has a softer membranous tube inside, and this, the cross section of which is now shown here, looks something like this, where the scala media is where you have the actual organ of Corti, and it has the inner and the outer row of hair cells. The scala media's contents are the endolymph. Now, endolymph is high in potassium, you must remember that. It resembles intracellular fluid. These cells have stereocilia, which are called hair loosely, and they impinge on the tectorial membrane. This tectorial membrane, as you know, when the sound waves come and cause agitation, they cause movement of the stereocilia, which results in a mechanically operated channel causing a generator potential in the hair cells. And that generator potential then eventually causes action potential of the cochlear nerve. The cochlear nerve then takes these impulses to the brain. So, in summary, the inner ear causes transduction, which is conversion of the sound energy into an action potential, but it also codes for loudness and frequency of sound. Loudness it codes simply by the frequency of action potentials of the cochlear nerve, and frequency coding is done by what is called the place coding principle, where the cochlea has a tonotopic arrangement, and this allows various frequencies to be detected at various points of the along the length of the cochlea. Now we are in a position to look at the two hearing pathways. What we have been discussing now is called the air conduction pathway, where the sound came through the air, impinged on the tympanic membrane, amplified in the middle ear, transduced in the cochlea, and then transmitted to the brain via the cochlear nerve. But because of the anatomical arrangement, any sound which is applied to the bone may go and stimulate the cochlea directly, because it will cause vibrations of the cochlea, and this actually can be heard as sound. But because bone conduction misses out on the amplification, generally speaking, air conduction is better than bone conduction in a normal person. A summary of hearing loss. Organic hearing loss is divided generally into three types. Conductive hearing loss. Conductive hearing loss is hearing loss due to problems with conduction. And because conduction is done in the external ear and the middle ear, problems such as wax, tympanic membrane perforations, pus in the middle ear, disruption of the ossicular chain, all of this can cause conductive hearing loss. Sensory neural hearing loss, on the other hand, is generally a problem of the cochlea, the inner ear with the hair cells, and or the cochlear nerve. And sometimes you may get a mixed picture. And this is just a diagram showing you the possibilities of some types of hearing loss. This is a piece of wax, perforation in the eardrum, pus in the middle ear, disruption of the ossicles. All that would give you conductive hearing loss. And if you have damage, maybe from medications of the hair cells and age-related hearing loss is called presbyacusis. If you have a tumor pressing on the cochlear nerve, all this may give you sensory neural hearing loss. So, with that we can then come to the assessment of hearing. And the assessment of hearing, one has to realize that hearing is a subjective phenomenon, and we must be sure that the person is listening before we can test his hearing. So, attentivity of the patient is paramount. Because of this subjectivity, sometimes it lends itself to inaccuracy, and there are other tests that have been devised to take care of this subjectivity. We must have certain environmental factors under control, such as the hearing tests have to be done in a quiet room. Under clinical circumstances, these are normally done in a soundproof room. And occasionally we have people who may feign their hearing loss either for gain or for suing for damages. hearing assessment is divided into four. Our purpose in these four steps is, number one, to detect the presence of hearing loss. Number two, if there is hearing loss, we would like to know the type of hearing loss, meaning is it conductive, sensory neural, or is it mixed? Thirdly, we would like to know the amount of hearing loss. Amount meaning how many decibels of hearing loss does this person have? And eventually we would like to know the cause of hearing loss. This would help us to determine what we can advise the patient for his problems. Let's take a break there and then we come back to the individual tests.